once again, thanks Dr. Sharma and management team. So first I will discuss regarding the diagnosis and risk factor of celiac disease. As Dr. Ravi Shankar already covered very well and made my job easier little. I will just discuss the risk factors. What are the risk factors? In Western world, it's around 0.6% to 1%. And if we see our Indian data, so it's 1 out of 96. If in North Indian data we see, published by Dr. Makharia et al. So 1%. Celiac disease is known to affect all age group and including elderly. And if risk is higher in monozygotic and dizygotic twins. If we see the data of monozygotic twins, it's around 70% prevalence rate in monozygotic twins and other autoimmune disease and especially Down syndrome. So celiac disease, it's a diagnosed and underdiagnosed condition because of heterogeneous presentation. Presentation is not uniform all over the world and clinical signs symptoms are very variable. So for diagnosis as an initial testing, the combination of IgA, a combination of total IgA and IgA class antibody against the transglutaminase, that is TTG IgA or TTG IgG, are far better than the other test combinations. So normally as a first test, we actually combine the total IgA level along with the anti-TTG IgA level. Titer of anti-TTG is more than 10 times the upper limit of normal. In that case, we can go for the next test and the next serological test and we can avoid the biopsy. However, if titer is less than 10 times the upper limit of normal, titer of TTG, in that case, we need a second sample, a serum sample and biopsy sample. And especially this recommendation regarding the titer is very true for, it's tested and true for the European population. HLA testings a few years back used to be very common in pediatric population, and but now it has been seen because HLA is, can present in 40% of population, normal population. So it has positive predictive value is very less. However, negative predictive value is high. So HLA testing is not obligatory criteria for serology-based diagnosis. But whom we test actually? So regarding the signs and symptoms, we see a lot of things are covered by the Dr. Ravi Shankar. And if you see the gastrointestinal symptom, so obviously chronic or intermittent diarrhea is the most common, and chronic constipation is also very common, especially in pediatric population, particularly those who are not responding to usual laxative and other treatment for chronic constipation. Chronic abdominal pain, abdominal distension, recurrent nausea, recurrent vomiting. These are the other features of gastrointestinal features. Extraintestinal features already covered. I'm just summarizing. So it's a weight loss, failure to thrive, stunted growth, short stature, delayed puberty, amenorrhea, irritability, chronic fatigue, neuropathy, arthralgia, iron deficiency, especially chronic iron deficiency anemia, and decreased bone mineralization, especially osteopenia and osteoporosis. And recurrent aphthous stomatitis is another common presentation of celiac disease. And dermatitis herpetiformis and dental abnormality, abnormal liver biochemistry. Patient can have the persistent elevated liver enzymes and sometimes can have chronic liver features of chronic liver disease. Other specific feature like first degree relative with, as we discussed, the various thyroid disease, liver disease, in family history of autoimmune type 1 diabetes mellitus, and other features can be associated with the celiac disease, as already discussed earlier. And next question is, if endoscopy, should we go for endoscopy and duodenal biopsy even if celiac disease serology is negative? If already discussed symptom, if we go for the serology and serology comes negative, then which group of patients should go for the biopsy? So in this regard, the recent European guideline recommends chronic non-bloody diarrhea, even if serology negative, one should go for the D2 biopsy. Diarrhea with a feature of malabsorption and weight loss, iron deficiency, anemia in absence of other obvious reason, other cause, and GI symptoms in patient with the autoimmune IgA deficiency, failure to thrive children, skin biopsy proven dermatitis herpetiformis, and if video capsule endoscopy incidentally detect gross villus atrophy. And it's also recommended for unexplained high output ileocolostomy. So these are the high risk clinical feature where we should go for the biopsy even if celiac disease serology is negative. So if transglutaminase antibody is negative, IgA is negative, then we have again the two scenario. So again we should review for the initial total IgA level. If total IgA is good, normal level, in that case we have to think there are conditions where a patient can have celiac disease and with high chances of seronegativity, like the dermatitis herpetiformis. So if transglutaminase antibody is negative, IgA is negative, and total IgA is good, sufficient level, in that case, if patient is high risk group, then we should think about the false negativity, and then we have to go for the biopsy and HLA testing. And if anti-TTG is negative and IgA level is also low, so again there are two scenarios. So now first scenario is if patient is having IgA level adequate and but anti-TTG level negative, IgA is negative. In that case, here the HLA is useful. Then we should go for the HLA, DQ and D8 measurement. If HLA is negative, in that case, celiac disease is unlikely. If HLA is positive, in that case, again we have to confirm with the biopsy. So again, I'm repeating. So if transglutaminase antibody is negative and but IgA total IgA level is adequate, in that case, scenario is again different. Then we have to measure IgG level of TTG or endomysial antibody or DGP. So if IgA level is low and TTG is negative, in that case, we should go for the IgG test. And if IgG test is negative, then we can consider risk of false negative serology. And if it's IgG test is positive, then we again have to go for the biopsy. So actually, it appears to be a little complicated. I am just summarizing again. If in case anti-TTG is negative, a patient is high risk of celiac disease. So in case IgA level is adequate, then we should go think about the seronegativity, particularly dermatitis herpetiformis. And in that case, we should go for the HLA measurement. And if HLA measurement is negative, then celiac disease can be excluded. And if it's a positive, then go for biopsy. If IgA level is low and the TTG level is also low, in that case, IgG measurement serology test should be measured. And if it's negative, then chances considered is a false negative serology. And if it's a positive, then again, we have to go for biopsy. So regarding biopsy, so what is the adequate number of samples? So normally we take a recommendation is at least 4 biopsy should be taken from distal duodenum, D2 or D3, and at least 1 biopsy from duodenal bulb. And after the taking biopsy, the proper orientation should be made by the endoscopist per se or endoscopist technician of endoscopic technician before sending to the histopathology, and it should be preserved in formally. If we, after taking biopsy, we see the grade of Mars grade, we know it's a Mars grade 1, 2, 3. So Mars grade 1 is just elevated intraepithelial lymphocyte counts, more than 25 per 100 enterocytes is considered as a elevated intraepithelial lymphocyte count. And it's and if there is no villus atrophy, then the algorithm is a little different. And if there is clear-cut villus atrophy, either subtotal or total, normally villus and crypt height is more than 3:1 ratio. But if it's less than 3:1 ratio, then we can consider it as a subtotal atrophy. And if it's villus height and crypt depth is equal, in that case, we consider it as a total atrophy. So both subtotal and total atrophy in presence of celiac disease is confirmed. However, if patient does not have biopsy doesn't show this villus atrophy, in that case, we should actually see the different algorithm. So algorithm is here again. If patient is having Mars 1 histology, that means I only raised intraepithelial lymphocyte. In that case, again we go for this serology, both anti-TTG and endomysial antibody. Then we have to go for both anti-TTG as well as anti-endomysial antibody. If both is positive, then celiac disease is likely, and if both is negative, celiac disease is excluded. And if one of them is positive and another is negative, in that case, we should go for the HLA measurement and HLA DQ D8 measurement. And if it's a positive, then we should repeat the serology and re-biopsy may be considered. And if it's negative, then basically celiac disease excluded. Most important thing here is we must inquire about the recent, if patient is not a first timer, in that case we should inquire about the recent intake of gluten. Sometimes patient comes to us with already patient already on after avoiding the gluten food products. So if patient is on gluten-free diet, then all serology tests can be negative. In that case, again, we have to rely on the biopsy and repeat biopsy after starting the gluten challenge. Normally, gluten challenge is not required. So with this, thank you very much.